Many patients present to me as a neurosurgeon with an MRI scan or a CAT scan that shows a mass in the brain, and they've been told that this is likely to be a tumor. At this point, it's not known for sure whether the finding on the MRI is a tumor. With experience, we can look at these scans, and as physicians, we start to make a list of the most likely diagnoses. And tumor may be the most likely thing, but a stroke, a blood clot, multiple sclerosis, infection, all of these things are on the list. The most important thing for getting a diagnosis of a brain tumor is to get some form of a biopsy or a tissue diagnosis. And by this we mean that a small or a large amount of the tumor is submitted to a pathologist who examines the tissue under a microscope, may look at the genetic makeup of the tumor, and then gives us a diagnosis as to exactly the type and grade of the tumor. Until we have a tissue diagnosis, and while we're basing all of our decisions on an MRI scan or a CAT scan, we're making educated guesses about what the tumor is. So it would be very common for a patient diagnosed with a new lesion in their brain to undergo some sort of a biopsy or surgical procedure to get a definitive diagnosis. When a patient is diagnosed with a mass in the brain and comes to meet a neurosurgeon, there's usually a recommendation to get a tissue diagnosis. This can be done one of two ways. The first is a simple biopsy, which is sometimes called a stereotactic biopsy, and the second is an open surgical resection of the lesion. Depending on the particular case, the age of the patient, their neurologic condition, the size of the lesion, and the location of the lesion, I might recommend to the patient either a biopsy or an open surgery. Let's talk a little bit about each of those and when we might recommend one over the other. The stereotactic biopsy is the simpler of the two procedures that can be done to get tissue to make a diagnosis of a brain tumor. The goal of the biopsy is to guide a probe or a needle down into the abnormality and take several small bites. Those bites are submitted to pathology and a tissue diagnosis can be made. Usually this is done with guidance from either CAT scan or MRI. This is very much like the GPS that many of us use when we're trying to get somewhere in the car. We can take the MRI scan and the surgeon can pick the exact spot on the MRI where they want the biopsy to come from. And then in the operating room, using a guidance computer, guide a probe down to that exact spot and take several biopsies. The biopsy procedure usually involves only a very small incision and one small opening in the skull that the probe passes through. It's not a treatment. We're removing only a very small part of the tumor, so it doesn't relieve the mass of the tumor, and it only takes out a small piece. But it does get us an answer very quickly, and it has only a very small amount of risk associated with it. The biggest risk is at the time of the biopsy, when that little bite of tissue is being made, that there could be bleeding. And that happens very rarely, maybe 1% of the time for each biopsy that's taken. Patients often go home the same day or the next day with just a small incision on the scalp. And then several days later, the answer will come back as to what the lesion is. Is it a tumor? And if it is a tumor, what kind of tumor? The advantages then of the biopsy are that it's a small procedure with a very short stay in the hospital. The disadvantage is that we only biopsy one small area. So if we have a large tumor, we take a bite from one small area, then we know exactly what that area of the tumor is. But there may be another area of the tumor that's a higher grade area, and we might miss that with the biopsy. Obviously, as a surgeon, I want to aim the biopsy at the area that looks to be the most aggressive or the most worrisome. But that, what we call sampling error, is one of the risks of the biopsy. I usually do a stereotactic biopsy in patients who I don't think I will ever be able to do a full removal of, or in somebody whose case is very atypical and I'm not sure if it is a tumor at all. If I see something that's very close to the surface and very easy to remove, rather than putting the patient through a biopsy and then bringing them back several days later and saying, yes, it's a tumor, let's go do an open surgery, I usually recommend going straight to the open surgery. And I'll talk in just a moment about what that is. So I tend to use the stereotactic biopsy for deep lesions that would be hard to remove, or unusual lesions where I'm not sure if it's a tumor or